Good morning. My name is Dr. Rohit Arvindakshan Kuloth, and I work as a consultant intensivist with Apollo Hospitals, Chennai. And today I'm here to talk about the topic on basics of recognition and management of sepsis. Now, sepsis is a very important topic for any new clinician to know about because of its major implications that it has as a disease and how it is a major public health problem that is worldwide. So it is not associated with any region. This is a problem that is there worldwide, and everybody needs to be aware of this disease and its mortality and morbidity that it has. Coming to the introduction and giving you a brief aspect about this disease, the incidence of sepsis varies between 33 to 100 cases per 100,000 population in the Western countries. And this is quite a high incidence. We don't have numbers from the developing nations, but it is still a major public health problem in the developing nations as well. So now, coming to the pathophysiology, just to give you a brief update and brief explanation about the pathophysiology of sepsis itself. As you have all probably learned in the pathology classes, the sepsis is basically a dysregulation, a dysregulated response to infection, basically no balance between the pro-inflammatory and the anti-inflammatory mediators, which finally lead to organ dysfunction. So in this first slide, what you can see is I have just depicted a picture of the bacteria which triggers a response in the body. Basically, the cell wall component, that is the lipopolysaccharide of the gram-negative bacilli and the peptidoglycan of the gram-positive bacilli, they attach to the receptors present in the white blood cells, and this leads to a transcription of immunomodulatory cytokines like tumor necrosis alpha, interleukin 1 beta, and the interleukin 10. What these immunomodulators do in turn is they cause an activation and binding to the macrophages, which in turn release the prostaglandins, leukotrienes, proteases, and oxidants. So this leads to a vicious circle where there is an increase in the pro-inflammatory mediators, which finally lead to organ dysfunction. The second pathway of the pathophysiology that is important is the activation of the intrinsic nitric oxide synthase pathway. Now this is activated and there is an increased release of nitric oxide from the endothelium, which causes the vasodilatation that is very characteristically seen in patients with sepsis. So the third pathway, that is the third important factor in the pathophysiology of sepsis, is the prothrombotic pathway. So the extrinsic pathway of the thrombosis is activated by sepsis itself, which causes a formation of microthrombi, which in turn hampers the microcirculation of the organ systems, which leads to organ dysfunction. Just to give you a brief idea about the Surviving Sepsis campaign. Now, this was an international collaboration that was set up in 2002 in order to improve the outcome of sepsis patients by setting certain guidelines and certain protocols in place so that the outcomes for sepsis was better. And this was a collaboration based on the European Society of Critical Care Medicine, the International Sepsis Forum, and the Society for Critical Care Medicine that came together in 2002 to set up these guidelines. Now, there was the concept of early goal-directed therapy initially, which was a quantitative target where they targeted physiological variables to basically protocolize these managements of sepsis according to certain quantified variables. But as per recent guidelines, the early goal directed therapy is no longer practiced because of the fact that there were three very important randomized controlled trials done in across ICUs in Europe, US, and the Australian nations, where the process arise and the PROS trials showed us that there was no benefit with protocolized management, rather having bundle-based care for sepsis patients. Coming to some important definitions and terminologies, so I would like to start with what is infection. So infection is essentially the invasion of sterile normal tissue by pathogens that are likely to cause an infection. So that is the basic definition of infection. What is organ dysfunction? So organ dysfunction is basically a SOFA score of more than 2, greater than or equal to 2. What is the SOFA score? So SOFA score is essentially a sequential or sepsis related organ failure assessment score. Now, as you can see, the SOFA score is based on 6 organ systems in the body, and parameters from these 6 organ systems are collected and the score is summed up. The 6 organ systems are the respiratory system, the coagulation pathway, the hepatology and biliary system, the central nervous system, the renal system, and you have your cardiovascular system. So in the respiratory system, the PF ratio is calculated, and for all the systems, the score is ranging between 0 to 4. Coagulation system takes in consideration to the platelet count. Then you have the liver, which calculates the bilirubin levels. Cardiovascular calculates the patient's blood pressure, whether supported or unsupported. Your CNS is based on the Glasgow Coma scale, and the renal system is based on your creatinine values. So organ dysfunction is essentially your SOFA score greater than or equal to 2 based on this score that we have. So coming to the definition of sepsis per se. Sepsis definition as per the third international consensus in February 2016 is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, every word in this definition is important, where it terms life-threatening. Organ dysfunction, as we have described what organ dysfunction is, caused by the dysregulated host immune response to infection. So there is a dysregulated immune response to the infection that leads to organ dysfunction. This is termed as sepsis. Septic shock. Septic shock is defined as a subset of sepsis with particularly profound circulatory, cellular, and metabolic abnormalities that are associated with greater mortality. So essentially, septic shock is a need of vasopressors to maintain a mean arterial blood pressure of more than 65 mm of mercury, or the persistence of lactates more than 2 millimoles per liter in the absence of hypovolemia. The term severe sepsis has been removed now from the definitions. So we have only sepsis and septic shock. So coming to the recognition of sepsis. Now, rapid recognition of sepsis and initiation of treatment is key to the management of these patients. There are several scores which are developed to detect patients early and initiate the treatment. So I am going to emphasize on two scores, that is the Q-SOFA score and the early warning score that was developed in the United Kingdom. Now, the SOFA score, as we had previously discussed, had to do with a lot of investigations, and it is quite labor intensive for its processing. So most of the ward patients may not have access to so many investigations quickly in order to plan for the management. So the Q-SOFA score was developed as a tool to recognize patients that are at high risk of mortality or morbidity. It has shown that a Q-SOFA score of greater than 2 identifies patients that can be at high risk for a poor outcome. The only disadvantage with the Q-SOFA score is that it is not sensitive to detect sepsis patients per se. So it has three basic components, that is the systolic blood pressure, altered mental status, and the tachypnea. So patients with a systolic blood pressure of less than 100, a GCS of less than 13, and respiratory rate of greater than 22 will score 1 for each criteria if it is bent. A score of greater than 2 would suggest a greater risk of poorer outcome. Coming to the early warning score. So the early warning score was devised so that patients that are admitted in the ward are recognized early who are at risk of sepsis and severe infection. So the modified early warning score, and we had the national early warning score. The variables, as you can see, is more or less the same in terms of the parameters that are monitored, and each of the parameters are scored based on the values. So you have the respiratory rate, the saturation, the temperature, the systolic blood pressure, heart rate, the AVPU scale, that is the alert verbal painful stimulus or unresponsive scale. Based on this, a score is made. Now, the Muse or the news chart is color coded so that it makes it easy for the care provider to identify such patients who are at risk and escalate accordingly. So, according to the news score, we have white, green, orange, and red as part of the color coding system on the chart. So 0 would mean continuous routine monitoring, a minimum of every 12 hours. A score of 1 to 4 would mean more often monitoring 4 to 6 hours by a registered nurse. Greater than 5 or 3 in one variable would mandate increased frequency to a minimum of once an hour. Such patients should urgently be assessed by a clinician with core competencies to assess acutely ill patients. Now, patients scoring a total of 7 or more will need to be continuously monitored and be assessed by a clinical team comprising of a person who has critical care competencies and also advanced airway skills. So essentially, the intensive care team should be involved if a patient is scoring 7 or more. So this color-coded chart makes it easier to identify such patients in the ward, and when they are scored at a particular score, the monitoring levels and the escalation of care is planned in an easy way so that these patients can be identified early and resuscitated. Now, there are a lot of research models and a lot of research involved in patients in the intensive care who suffer from sepsis, but it is important to understand that recognition of such patients start outside the ICU setting. that is maybe out of hospital or inpatient or in the emergency department. And it is essential for non-intensive care professionals also to recognize such patients so that treatment can be initiated at an early stage. Now that we know about how to recognize such patients, what are the investigations that are done for such patients? So the investigations are essentially based on the organ dysfunction that we are trying to detect. So we have the full blood count, clotting profile, prothrombin time, INR, urea and electrolytes, liver function tests, the serum lactates and the ABG. The most important thing is to obtain microbiological samples, and the Surviving Sepsis campaign guidelines recommend 2 sets of blood cultures to be sent from patients having suspected sepsis. Now, why 2 sets? The second set increases the sensitivity from 62 to 90% in order to detect the bacteremia in the blood. So the cultures and susceptibility reports help us to identify the species and sensitivity to the antibiotics we have started the patients, so that we can de-escalate the antibiotics that are not required, which is a very important aspect of antibiotic stewardship. In addition to blood cultures, other cultures can also be sent from relevant sites like the urine sample or cough sample in case there is suspicion of such systems involved. So coming to the management of sepsis. In the management of sepsis, the latest 2018 guidelines and update as per the Surviving Sepsis campaign shows us that the bundle of care to be followed for septic patients. So the bundle of care involves measuring lactate level, remeasure if initial lactate is more than 2 millimoles per liter, obtain blood cultures prior to administration of antibiotics, administer broad spectrum antibiotics, begin rapid administration of 30 ml per kilogram of crystalloids for hypotension or lactate greater than and equal to 4 millimoles per liter, and apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain a MAP of 65 mm of mercury. So these are the basic steps in the sepsis bundle of care as per 2018 update. So as per the SSC campaign, the 1 hour bundle, this is a pictorial representation of the basic steps that we have discussed on the septic bundle. So step 1 is the measurement of lactate levels, remeasure if initial lactate is elevated, that is more than 2, obtain blood cultures before administering antibiotics. Number 3 is administration of broad spectrum antibiotics. 4 is beginning of rapid administration of fluid resuscitation, and 5 is application of vasopressors if hypotensive during or after fluid resuscitation to maintain a MAP of more than 65 millimeters of mercury. So all these steps are done within the first hour of recognizing a patient who could have possible sepsis. Antimicrobial therapy is a key component in sepsis, and this needs to be managed very scientifically in terms of how we provide antimicrobials as prescribers. So clinicians should follow local guidelines, which should also be based on local antimicrobial resistance patterns. The antibiotics should be started within first hour of recognition of sepsis or septic shock. The regimen should be reassessed daily for potential de-escalation. Use of low procalcitonin levels or similar biomarkers can be used to assist the clinician to either discontinue empiric antibiotics in patients who initially appeared septic, but they have no subsequent evidence of infection. Coming to combination empirical therapy, This is important to understand and recognize these subset of patients which would benefit from combination empirical therapy so that they can cover a wide spectrum of infection. Who are these patients? These patients are neutropenic patients, patients with severe sepsis or SOS being difficult to treat, multi-drug resistant bacterial pathogens like Acinetobacter and Pseudomonas, severe infections associated with respiratory failure and septic shock. So these patients will benefit from combination therapy like extended beta-lactams and aminoglycosides and fluoroquinolones. Another example is for patients suffering from Streptococcus pneumoniae, we usually start them on beta-lactams with macrolides. So the empirical combination therapy should not be generally administered for more than 3 to 5 days, where we should be able to get the culture reports and de-escalate to appropriate single therapy. The duration of antimicrobials can range anywhere between 7 to 10 days. The next important the management of sepsis is the source control. Now, the source of infection should be diagnosed or excluded as early as possible within 12 hours. For example, if there is a peripancreatic necrosis, a delayed definitive intervention is planned. If there is an abscess, like a skin or soft tissue abscess, percutaneous or surgical drainage of these abscesses should be done. If there are IV lines and basically strong suspicion of catheter-related bloodstream infections, the IV device itself should be removed, which could be a source for the sepsis. So coming to other supportive measures apart from antimicrobials in septic patients. Coming to other supportive measures in the management of sepsis, infection prevention with features like hand washing, limited patient contact, prevention of ventilator-associated pneumonias with propped up position are some of the measures that are used. When we talk about blood products, once tissue hypoperfusion has been resolved, transfusion is indicated only if the hemoglobin is less than 7 grams per deciliter. Fresh frozen plasma is used mainly for planned invasive procedures with patients having high INR and patients who have bleeding manifestations, and it is not used for correcting lab clotting abnormalities in the absence of these two indications. When we talk about platelets, platelets are prophylactically transfused when the count is less than 10,000, even in the absence of apparent bleeding, less than 20,000 if there is a risk of bleeding, or less than 50,000 if active bleeding or a planned surgery is taken up. There is no use of selenium or immunoglobulins in septic shock or sepsis patients. Mechanical ventilation of patients in sepsis with ARDS is as per the ARDS lung ventilation protocol, that is lung protective ventilatory strategies used in regular ARDS patients. So you have tidal volume of 4 to 6 mils per kilogram and maintaining a plateau pressure of less than 30 centimeters of water. These are used in sepsis-induced ARDS as well. Now, glucose control, if 2 consecutive blood glucose levels are more than 180 milligram per deciliter, generally insulin is commenced to achieve a target of less than 180. So, glucose monitoring every 1 to 2 hours is recommended until the values are stable. So, the other factor of glucose control is that it is shown that tight control regime does not have any mortality benefit in patients, and so that is why the target is fixed at around 180 milligram per deciliter. Deep vein thrombosis prophylaxis is also important in such patients, as we had discussed earlier about the prothrombotic tendencies in such patients. So low molecular weight heparin is commonly used. If patients cannot be started on chemical deep vein thrombosis prophylaxis, we use physical methods like graduated compression stockings or intermittent compression devices where they can be started on patients. Such patients are also prone for stress ulcers, so stress ulcer prophylaxis is also started with either a H2 histamine blocker or a proton pump inhibitor. Nutrition also plays a vital role in patients admitted with sepsis and septic shock. Oral or enteral feeding as tolerated within the first 48 hours of diagnosis is recommended. We start with a low dose feeding in the first week and advanced only as tolerated. There is good enough evidence to show that early enteral nutrition is actually advantageous for such patients as it has a good role in maintaining the gut integrity and to help build up the nutrition of such patients in terms of tolerance. So, to sum it up, the take-home messages of today's topic are as follows. The quick sequential or sepsis-related organ failure assessment score, that is the QSOFA score, can be used by clinicians as a bedside tool to identify patients with infection who may have sepsis. So as we noticed earlier, QSOFA is positive if the patient has at least two of the following criteria, that is respiratory rate of 22 minutes per minute or greater, Glasgow Coma score of less than 13, a systolic blood pressure of 100 or less. So a score of 2 or more would have a positive QSOFA score. The other score that we talked about was track and trigger early warning scores such as the Muse and News scores that can also be used to identify deteriorating patients with infection who require rapid treatment for sepsis. The clinical diagnosis of sepsis should trigger appropriate management bundles such as the Sepsis 6 bundle. As per bundle to be completed within 1 hour of diagnosis of sepsis, we administer oxygen to maintain a saturation of greater than 94%. We take blood cultures and consider the infective source, administer intravenous antibiotics, consider intravenous fluid resuscitation, check serial lactates, and commence hourly urine output monitoring. Now to talk about a brief description of what antimicrobial stewardship is. So antimicrobial stewardship is an important topic. It is basically a systematic effort to educate and persuade prescribers of antimicrobials to follow evidence-based prescribing in order to stem antibiotic overuse leading to multi-drug resistant organisms. Hospitals should ensure that all medical staff are familiar with the diagnostic criteria of sepsis, the guidelines and the bundles. It is important for us to know about this particular problem because of overuse of antibiotics that are quite rampant worldwide, leading to an emergence of multi-drug resistant organisms. So such guidelines should be followed closely in the hospitals, and prescribers should always be aware of their local antibiotic guidelines which are basically in place. Now it is important to recognize and identify other possible diagnoses apart from sepsis. So there are a lot of disorders that can present like sepsis but need not be sepsis. So what are all the non-infectious mimics of sepsis? We have acute myocardial infarction where the patient can be hypotensive, can be tachypneic and breathe at a faster rate. You have acute pulmonary embolism where the patient can be hypoxic, tachycardic and hypotensive. You have patients with acute pancreatitis that can have a fever, that can be hypotensive and at the same time hypovolemic, which can mimic sepsis, fat embolism syndrome, acute adrenaline insufficiency. Such patients who are on long-term steroids, who have stopped the steroid suddenly and can have an acute adrenaline insufficiency presenting with profound hypotension, patients with an acute gastrointestinal hemorrhage, overuse of diuretics, transfusion reactions, adverse drug reactions is also very important as a mimic of sepsis, and of course amniotic fluid embolism. So it is important for the clinician to keep the differential diagnosis also in mind of such patients presenting with similar symptoms and signs of sepsis and septic shock. So this brings me to the end of my talk today, and basically I would just like to emphasize that sepsis is an important disease, and it is important that we recognize this early and initiate treatment early. And basically we have the evidence that antibiotics and fluid resuscitation, vasopressors that are started early can have a great effect and improvement in patients who are suffering from sepsis. I hope this talk will be useful for the clinicians listening into the program, and we can tackle this problem with sepsis in a timely manner. Thank you very much for your patient listening.